So good evening, everyone. I am Ashish, and I'm the chairman of Freedom Foundation. My basic job is a cardiology-based role, but I do like to do lots of things, including interacting with people, running a charity, so on and so forth, along with my wife Smita, who's also joining us. Thankfully, both of us are in India currently at different places. And hi, Liam. So we will start this symposium, which you already have a full program of, which is themed on winter wellness and seniors, collaborative focus on elderly health. So basically, we have been thinking about this for a very long time, perhaps 3, 4, 5 months, as to how to structure it, how to do it. And then eventually we came out with a program which I wouldn't say is the first one, but there'll be few more to come in future. But this should set some stones, and everyone should go back with certain messages. So thank you all for joining so far, and all those who join a bit later on, and feel free to interact. So I would start the program by inviting. We have about 13 minutes inaugural remarks. So can I request Professor B.B. Thakur, who is the chairman of Hridayam Foundation, India, to give his inaugural remarks. Thank you.
100%. Good evening, good afternoon, everybody. I would like to introduce.
Good afternoon, Professor Thakur.
Teachers of teachers. My professor. This.
Anand, can you mute people, those who are, and put the speaker view, please? Thank you.
Please mute.
Thank you. Please go ahead, Professor Thakur.
Good afternoon, friends from both sides of the world. My teacher, Professor S.N. Arya, teachers of teachers, Professor Arya, distinguished faculty from both sides of the world, respected delegates, ladies and gentlemen. It's my privilege to extend a very to all of you on behalf of the Hridayam Foundation UK and India, Association of Physicians of India, and Indian College of Physicians, national and local. We are grateful to Professor Jyotirmay Paul, President of Association of Physicians of India, Dr. Kamlesh Tiwari, Professor Kamlesh Tiwari, incidentally my student also, Dean Indian College of Physicians, Professor P.K. Agarwal, Chairman Bihar Chapter of API and ICP, Dr. Manish Kumar, President Rheumatological Society of India, Bihar Chapter, and erudite faculty from both sides of the world. It's very heartening to see your willingness to participate in the important program at such a short notice. It speaks very high of your commitment to healthcare. At the outset, I would like to particularly acknowledge Dr. Ashish Kumar Thakur, founder of Hridayam Foundation, chairman UK chapter, whose vision and commitment has made today's event possible. I'm happy to inform you that, like previous years, our foundation is currently running flu vaccination program from today till 24th of October, which has been very well accepted by people at large. I had my jab. You can see just now this logo on my body. Our foundation is committed to prevention of NCD, non-communicable diseases, and their management, along with regular CME for educating our brethren at large on the principle of service to man is service to God for the last nearly 25 years. We all are aware that the number of senior citizens is steadily rising worldwide, and the current figure stands at approximately 1.2 billion in the world and 149 million in India. And this is going to be very high because of the current status of our health management. You all will agree that good number of them are either living with comorbidities or are susceptible to seasonal respiratory infections and other problems. Preventive healthcare, especially through timely vaccination, is therefore of utmost importance. The Center for Disease Control, Government of India, and the Geriatric Society of India has highly recommended about vaccination to all the people at large, especially the flu vaccine, hepatitis B, herpes zoster, pertussis, tetanus, etc., as and when appropriate. We are fortunate to have among us a distinguished faculty who will be guiding us through evidence-based strategies for elderly health protection. I once again welcome you all and wish the deliberations a great success. Thank you all for very patience hearing. Thanks a lot. Good night. Good evening.
Thank you, Professor Thakur. Thank you so much for your kind words and your very generous introduction and welcoming everyone on behalf of the foundation. May I now kindly request Professor Jyotirmoy Paul, President of the National Association of Physicians of India, for his inaugural remarks, please.
Thank you, Dr. Ashish Thakur, Professor B.V. Thakur, President of this organization and past President API, Dr. Kamlesh Tiwari, Dean ICP, Dr. D.P. Singh, and all the dignitaries, all the delegates, all the students. I must congratulate the Hidayam Foundation for taking such initiative, particularly on the preventive health. We physicians, we are happy if we treat a patient and get cured, but we hardly think about the preventive aspect. So all the organization, not only API, any organization, we are least bothered about spreading the knowledge of prevention among the population. And today, on the day of Dhanteras, you have chosen a right days, because Dhanteras popularly is known the day of the Dhan, means wealth, but it is not actually as we thought. Dhanteras came from the word Dhanvantari. During Samudra Manthan, Dhanvantari came out with the Amrita Kalash. So Dhanvantari is a god of the medicine. That means health is the wealth. So that is why we must take care of the health of our population, particularly the elderly population who are very vulnerable during the winter time. They suffer from multiple infections. So there is an ample scope to give prevention or protection from the different infection. There is a lot of vaccination is there that can be advocated, but our awareness of the elderly vaccination is very poor. Also, this winter time, the elderly often more suffers from different cardiovascular disease more and more. So there is a scope of prevention, and if we can spread the message of prevention of different diseases among the population. Today, I may not be of the elderly age group, but tomorrow I will enter the elderly age group. So this knowledge should be percolate to every sphere of the populations. And I hope this webinar will be very much useful and helpful to keep the elderly well. Thank you, and I wish all success of your program. Over to Dr. Ashish Thakur.
Thank you so much, sir, for very kind and apt words. There can't be any better way to start a session and having this from the National API President. And I hope that your initiatives through the year would also go a long way in senior people health, and we'll have many more meetings like this together. I'm now requesting Professor Kamlesh Tiwari, who is the Dean of Indian College of Physicians, to kindly give his opening remarks. Can I request Professor Thakur to put him on mute, please? Thank you. Professor Tiwari.
Thank you, Ashish. Thank you very much.
DICP.
Respected seniors, Professor Arya, Professor Thakur, and other dignitaries present here, even President API, Dr. Jyotirmay Paul. As Dr. Thakur said, I am his student, but I am sitting here with my student as well. Dr. Karuna Sharma, I can see, she is in England, but she is my student. Anyway, Dr. Ashish has put this program very nicely, and when I saw this program, I thought it was for us, myself, Dr. Thakur, and Dr. Arya. That's very nice of him. It will go very nice, and it will. Most of the people will be benefited by this program. It is a awareness program, and most of the people are conscious now. So thank you very much for keeping this program, and we will enjoy and take advantage of this one. Thank you.
Thank you, sir, for your such kind words. And really, this has really been on the minds for a long time as our thoughts are aligned with each other. And I'm sure all of us will learn something from the distinguished faculty. We're going to cover lots of things, so let's look forward to a very, very interactive and nice session. Can I, to finish off this initial bit, request our dear colleague, Professor P.K. Agarwal, who is the chairman of the Association of Physicians of India and also Indian College of Physicians, Bihar and Jharkhand chapter, for his quick inaugural remarks. Professor P.K. Agarwal, please. Is Professor Agarwal online? I think I saw him.
Thank you, Dr. Ashish Thakur.
Thank you, sir.
Respected dignitaries, Professor S.N. Arya, sir, the teacher of teachers, Professor P.V. Thakur, Chairman, Hridayam Foundation, Professor Jyotirmay Paul, President API, Professor Kamlesh Tiwari, sir, Dean ICP, my colleagues, distinguished faculty, and dear participants. Good evening and warm greetings to all. It gives me immense pleasure to be here today at this unique and timely symposium focusing on winter wellness and senior health. This initiative beautifully aligns with our collective mission to promote evidence-based compassionate and preventive health care for all, especially our senior citizens who deserve our utmost care and respect. I wish to place on record my deep appreciation for Professor B.V. Thakur, whose vision and leadership through Hridayam Foundation continue to inspire such impactful initiatives. To Professor Jyotirmay Paul, our dynamic president of API, for his continuous encouragement to bring academics closer to community health, and Professor Kamlesh Tiwari, sir, Dean ICP, for his dedicated focus on academic excellence and mentorship of young physicians. A special word of appreciation to our Dr. Ashish Thakur, Chairman, Hridayam Foundation, UK, whose tireless efforts in conceptualizing and coordinating this event across continents truly demonstrate that compassion and collaboration know no geographical boundaries. Friends, as Chairman of API Bihar, I feel proud that our association is partner in this noble effort. Together, through shared learning and specific dialogue, we can develop practical, holistic strategy to assure that our seniors not only live longer, but live healthier and healthier. Thank you you all, and I wish the symposium a grand success. Thank you.
Thank you, Professor Agarwal. What a beautiful introduction, and we're really honored with your kind words, and also honored for you to be chairing the API ICP Bihar Jharkhand Forum. I'm sure it'll take big leaps, and we'll have similar Bihar and focused meetings going forward. So with that, we rather literally come to the end of the inaugural session and dive in straight in to the program itself. So our first session is, as you all know, is titled on, is themed on winter, age, and frailty, risks and worries. So can I have, and we have a few very relevant faculties, including, one of our senior most physicians from the country, Professor S.N. Arya, who's kindly joined the session. So before I bring Dr. Arya in, can I have Dr. Abhay Das? Abhay, are you around?
Yes. Yeah.
Oh, hi. Hi, Abhay. So Abhay is quite a senior geriatric consultant in England, a good colleague of mine. And I'm going to put him a question as we, agreed the format. Abhay, you've got such a wide experience. I know you're running around every day. I see you almost now and then. You manage such a large burden of elderly patients. But do you think, my question to you is very, very straightforward. And this is for the wider audience across both continents, that what is age? And, India's population set aside, Bihar population projected as of 2023 caste census is 123 million, which is double the population of the whole of UK, out of which the projection from 2023 caste census was that we only have 7.7 or 8% of population is elderly. So do you really think that we should worry about this too much? Number one.
Absolutely.
Number two, legally, we are entitled to say that once you are 60 and above, you're a senior citizen. That's the legal requirement in India. Do you think that's reasonable, or do you think that completely contradicts the focus of elderly medicine and takes away what we do in England, for example, is 70, 80, 85 plus. So I'll over to you for your thoughts. Thank you. Bye-bye.
And thank you very much, Ashish, for giving me the opportunity to talk. And your first question about the aging population and the statistics you have given, you have to take it with a pinch of salt because many people do not have an actual date of birth. Like I'll give you my example of my brother-in-law, that his date of birth is not the right one, what is shown on the document like the Aadhaar. Same thing, in UK, if you find somebody's date of birth is 1st of January in so-and-so year, that is clearly that it is not the correct, it is for the record, it is the date of birth, but the actual date of birth is not known because birth and date registration was not mandated in those days. So I think Professor Arya told the total population of elderly people in India is 149. So if I take that statistics, it is at least 10%. So 7.7% is lower than that. So first and foremost, our number of older people is higher than what it is shown on record. And with increasing age, with people living longer, with expected age at birth is increasing, I'm sure it is going to going up and up. Regarding the limit, when you say above 60, is it the right age to say that elderly or senior citizen? Probably not. Time has come in India also to think it. As you know, I'm just giving the statistics for the benefit of everybody else that in UK, when I started my job, that time the age cutoff for elderly was 75. Before that, it was 65. Now, practically there is no age cutoff, and my patients' average age is between 90 to 95. There are above 100. Every month, I'll get few patients who are above 100. So, because on an average, life expectancy is about 10 years more in Western countries compared to India. So you bring that.
Let me just quickly interrupt you. I'm very sorry for that.
Yeah.
Linked into that, of course, was a little question which you will love to answer. Would be, where does frailty come in between? When you're saying 60, 70, 80, 90, 100, frailty, where do you see that within this whole context?
So frailty is basically a process where with physiological decline with the aging process, if there is a pathological component to it, like as you grow old, you will lose our muscle. I will be weaker, we will have poor strength. But if it is pathological, like significant sarcopenia, that will make my grip strength much weaker, and that will make me at risk of falls. So it is not a physiological process, but it is an accelerated physiological process, which will lead to any stress, like you have an infection, you have surgery, you had a medication with normal side effect, but that side effect will be much worse for me. So 1 + 1 = 10, not 2. So that's the concept of frailty. With age, it has got a link, because this process starts with age, but not necessarily age can, increasing age will lead to frailty. And also there may be minor group of people who will be not that old but frail. So basically biological age and chronological age not always correlate with frailty, but most commonly with increasing age you lose our physiological reserve, and a minor insult is basically blown out in a much serious way. Like a young man falls and trips on the slippery road or something, he will not have any problem. But an old person will end up having a significant problem, like a fracture or head injury, or he'll be bedbound, his mobility will be poor, he will develop pneumonia. Ultimately, there is a risk of dying. So frailty leads to increased mortality, increased morbidity, increased length of stay in the hospital. And that's why when you come to the age cutoff, like you probably know, in our elderly care assessment unit, it's not the age, it's also the associated frailty. A patient who is only 65 years old, he will be admitted to under the elderly care, provided he has a previous stroke, he's bedbound, or he has got poor mobility. Or a patient with 60 years old, advanced Parkinson's disease, that itself will make him eligible to be looked after by the geriatricians. I
Thank you.
hope.
Yeah, thank you, Ajay. Abhay, sorry. Did I interrupt you on something very key?
Fine.
Right. So I'll hold you. I'll ask you to hang fire and hold on to your thoughts for now. We'll move on to the next speaker, and then we'll have some time for a joint discussion. In the meanwhile, you can think about the winter aspects and how all that is going to kick in. So let's move on to the second panelist for this session, who is a senior general practitioner in UK and also works in India for our foundation, as co-director, Hridayam Foundation, Dr. Smita Thakur. Smita, are you on?
Yes.
Hi, Smita. So, welcome. Have you been able to, working on both sides? I know you see, like Abhay said, that he visits, he sees patients who are 80, 90, 100 plus. I'm sure you'd be seeing them in a much more different or similar context, not in the hospital, but maybe community, their homes, here and there in different conditions, good, bad, worse, whatever. Compared to that, how do you see that different in Bihar in terms of elderly? We are here in a situation where everybody wants the senior citizen benefits as soon as we hit 60 years of age. But no, we don't want to be called elderly. So as Abhay has said, that this thing needs to change, perhaps at some point. But where do you see the two sides different? Thank you.
Thank you, Ashish.
Any specific issues to Bihar, actually?
Yeah. So the most important thing is I'm in a remote village in Bihar, not where Ashish is, and my internet is very unstable. So if there is an issue, I'll have to put my camera off so you can at least hear me. So I would like to thank Hridayam Foundation for giving me this opportunity to be a panel member on winter wellness, focusing on elderly health. As a general practitioner in the UK, 2/3 of my patients are elderly, whom we care for either in the clinic or as in their homes, as home visit if they are frail or if they are housebound. And also a very large cohort of patients in the Hridayam Foundation are elderly as well. So I do have experience of looking after elderly patients across both continents. So when we think of winter problems among older adults, we often imagine the same things globally and a little extra care is needed. But when we look closely at Bihar, we realize the problems are similar in name, yet very different in nature and impact. The elderly people in Bihar will face challenges shaped by poverty, poor housing, lack of heating, and limited access to health care. So while the medical issues may sound the same, the lived experiences, the risk, intensity, outcomes are quite different. Let's begin by looking at winter issues which are common globally. In cold weather, older people naturally face certain biological and health-related issues. Every winter, we see a spike of respiratory infections, risk of hypothermia, poor blood pressure control, leading to stroke, myocardial infarction, increased risk of falls. These are universal problems, whether on an elderly who's living in Delhi or Darbhanga or Denmark. But in Bihar, the environment amplifies all these risks. So how is Bihar different? Firstly, housing and heating. In Western countries, winter preparedness is built into the system. Insulated homes, central heating, emergency helplines, social care services that check on the seniors. In Bihar, most rural homes are built of brick or mud. With little insulation, night temperatures in December or January can dip as low as below 10 degrees. And what do they have? No heaters, just a thin blanket or a small charcoal fire. That's not enough for an aging body at all. Secondly, the indoor air pollution. To stay warm or cook, the families in Bihar will burn wood, either cow dung or coal inside a closed room. That fills the room with smoke, which worsens asthma and COPD, which are common illnesses of the elderly. Adding to all of above, poor nutrition, limited access to health care, and low vaccination rates. And you have a perfect storm of vulnerability. Thirdly, most important is the mobility and access. In West, a simple trip on ice, the ambulance comes within minutes. In Bihar, a fall may go unnoticed for days because of fog, distance, and lack of transport. Dense fog can disrupt transport, delay ambulances, and even discourage the elderly from going out for regular checkups or medicines. If a doctor is about 10 kilometers away, that distance becomes nearly impossible on a foggy and cold morning. Often the women bear the brunt of it because they are the ones to eat last in the family as with social cultural norms. They wear thinner clothes, sit very close to smoky fires. Other than these, there are malnutrition, vitamin D deficiency, which worsen their immunity as well. And finally, we have the social factors. In West, the elderly often have pensions, social support, and medical insurance. While in Bihar, many families, the younger members migrate for work, leaving their older parents in the villages. Loneliness, limited income, lack of immediate help turns a mild cold into a medical potential emergency. And also, because of lack of mobility, these vulnerable people are also have an issue with neglect. And unlike that, in the West, where there's awareness about winter risks, in Bihar, the cold is still seen as something to tolerate, not to protect against. So while Western countries battle temperatures, Bihar is battling circumstances, poverty, housing, self-neglect. So what happens as a result? A lot of cases, deaths are reported in Bihar related to winter illnesses and cold exposure, most of which can be prevented. But these are not just deaths due to temperature, it also due to poverty as well. Policy wise, there's lack of awareness of winter preparedness, immunization, pneumonia vaccination programs for the elderly. Hirden Foundation had made a small effort, so there was a vaccination program. So we did manage to vaccinate a few. Beyond that, beyond the physical health, there's mental health, shorter days, cold isolation, reduced mobility, brings in loneliness, depression, things we rarely measure, but elders do feel deeply about it. So is it the same or different across West and the East? Answer is the illness is the same, but Bihar is starkly different. Winter is not just a season, it is a social test of how we care for our elders. With warmth, awareness, community care, we can make sure that no elder person in Bihar suffers simply because the nights are turning colder. We may not have central heating or senior citizen welfare system like the West, but small community-based action can make a difference. In the West, winter is a season to prepare. In Bihar, it is a test of resilience.
Thank you. That's a perfect way to finish. Yes, test of resilience. And I think I was looking at some statistics from 2023 projections and for Bihar, and it's interesting that despite Bihar having the least percentage of elderly population in India, with the state of Kerala having the highest, and Bihar being the third from the lowest, the literacy rates are the worst. So literacy rate in elderly people, illiteracy rate can be as high as 80%, and that perhaps adds a lot regarding understanding of the whole issues, problems, discussions, polypharmacy, seeking help, ignorance. I mean, we could keep making a list, and this could be a topic for a whole full symposium. But we'll take a break. We'll put you on pause for now, Smita, and move on to Dr. N.K. Singh. Thank you for agreeing, sir, to come on board at a short notice. Dr. N.K. Singh doesn't need introduction. He's a senior consultant physician in Dhanbad. He's also vice president of RSSDI, and also to be very people must know that he runs the largest group of CME group in the world. He might tell about how many doctors it has, but that's the busiest group of physicians across the world, which interacts 24/7 and is a fun to be on. And I'm glad to be part of it. Over to you, Dr. Singh. And I'm going to ask you a question. Are you on, Dr. Singh? Can you pin Dr. Singh, please?
Yeah.
Yeah. So Dr. Singh, welcome from all of us. My question to you is quite straight, as we discussed, that why do people die a lot in winter? Why there are so many deaths in senior people? And can you find some links which we could, or government or healthcare agencies should look at, and comorbidities? It's a very, very simple, straightforward question. Cardiac arrests, cardiovascular deaths, respiratory deaths. I mean, we've had so many. Every year we lose so many patients under our foundation. Sometimes we never find a cause. Thank you. Over to you.
Yeah, good evening, Asif. I think a great opportunity for me too. So I think very nicely, and I'm really highly impressed that Smita Thakur has given the input. And there is nothing more to tell that how our part of world, that is in Bihar, Jharkhand, Odisha, and other parts on north, they are doing. So I think you are basically concerned in winter about this silent killer season. So what we get more in our day-to-day clinical practice in winter, we get more heart attacks, strokes, respiratory failure. Such things are really very common. So what happens that although Smita also pointed that older adults have impaired thermoregulation problem also when temperature drops. So definitely there was a very good study by Dr. Gurpreet Wander sir that he showed that there was definitely increase in blood pressure also in winters, and that happens due to vasoconstriction, afterload increases, and also the sympathetic surge, tone surges, that rising heart rate, so platelet stickiness improving, increasing in the winter. So definitely this becomes blood becomes more viscous. So spikes in coronary events we are getting a stroke, we are getting sudden cardiac death, and basically what we find in most of history part that is happening in the morning hours when the temperature is lowest. So I think we have got a study from Delhi to Lucknow and even Patna that's showing that 15 to 25% rise in cardiovascular mortality during December to February compared with summer months. So this is very, very alarming. So what we can do, I think what is happening also that there is a cold air that is impairing the mucociliary clearance, surges in COPDs, and that burning part that Smita told that lots of pollution problem also that is leading to platelet stickiness, and we are getting lots of asthma attacks, pneumonia, influenza. Sometimes even this part intermittently, we are giving some COVID-19 relapses also at present. So there is poor ventilation also, or lots of problems are there. So what is the socio-environmental Indian factors are definitely have got that is concerns with the housing quality, the energy poverty, the nutritional part is also bad, definitely. So impair in the immunity part, delayed health seeking, lots of changes also in the what we are eating, and sedentary habits have increased, and that also increases more in the winter because due to the cold part, and your pollution already you told. So what but would like to say you that every 1 degree centigrade fall in the mean temperature, definitely there is 3 to 5% increase in all cause mortality, and definitely that leading to cardiovascular strain. Now, what is most important, what we are going to do as a practical prevention and policy part that you also asked. So we can encourage the layered clothing, indoor warmth after the sunset, that is one. And we can tell our patients to continue morning walk sometime later in the part of day when the temperature rises. That could be a good and very simple advice. Maintain the adequate hydration and monitor the BP. That is very important. You have more intense monitoring of the blood pressure in the winter, and definitely that part was also touched by Dr. Smita that in our part there is very, very low acceptance of this influenza and the pneumococcal vaccination. And I think, although I think really I'm really grateful that at a BBC concept and your concept that you are vaccinating, you have started a vaccination program for that. Even now for the pneumococcal part, I think Pneumo 20 has come in India also, and only one shot is needed. Apart from the also very good quality influenza vaccine which you need to give every year. So I think this poll for policymakers, for NGOs and people like you, they are promoting that. So I think my closing message will be that winter mortality in Bihar or in India is not a mystery. It is predictable, preventable public health phenomena, and it is born of the climate, culture, and chronic disease. Thank you very much for the opportunity. Thank you, Asif.
Thank you, Dr. Singh. That's a very, very, very holistic way to put things, and I completely agree with with all the three panelists so far. And I think the preparedness for winter is key, and this is what we were aiming to at least think about today, or forced to think when we leave this meeting, that we need to do something every year to try and see if we can prevent mortality, morbidity, especially as we get older. No one's going to get any younger. And Abha has so nicely summarized the difference between age and frailty, and differentiating between the two was really fantastic. So let me just now invite our guest of honor, Professor Dr. S.N. Arya, for his quick comments before we close this session. But please, all faculty, stay around because you'll have an opportunity in the next ones to give your give your comments. So Professor S.N. Arya is with us. We've said hello to him. And
अब बोलिए सर, आप जो बोले आप बोलिए, आराम से बोलिए।
can we pin him, please? Anand, can you pin
बोला।
Dr. Arya, please?
बोले
हाँ बोलिए, एकदम आराम से बोलिए सर, बोला है गुड सर।
Good afternoon, Professor Thakur. Thank you very much for having spared your valuable time to take part in this seminar or symposium. Professor B.B. Thakur has been my student, a very brilliant one, and then he became a professor of medicine also. Professor Ashish Kumar Thakur, worthy son of a worthy father, and Dr. Smita Thakur. I thank you all for having graced this occasion. Dr. B.B. Thakur, Professor B.B. Thakur, had always inspired many such conferences, and I can tell that he is
सर है, सर is listening, sir is listening,
Hmm?
sir is listening, sir is listening, sir is listening.
Yes, sir.
Yeah. Sir wanted to know that what is your opinion for the elderly patients when they came into the winter season? So what is your
आप अपना छोटा सा मैसेज दे दीजिए
कि elderly patient के
elderly patients have many handicaps. Number one, their immune system is weak, and they cannot adjust to the changed circumstance. And elderly patients have diminished immune system, diminished reactivity of immune system. Elderly patients have diminished capacity to readjust to changed circumstances. I thank you all for having graced this occasion, and I thank Dr. B.B. Thakur for having given us this opportunity to be with you all. Thank you very much.
Thank you, sir. Thank you, Professor Arya. We are so ever grateful and we will ever be grateful to you for all times to come. This meeting is being streamed live on YouTube as well, so which will stay forever, and I'm sure we'll have a chance to visit this back and listen to you again for your kind thoughts and views. With that, we will come to the end of this session and move on to our next theme, which is infection prevention and vaccination. Now we are going to do some provocative bits and how to fill the gaps. We have three panelists: Professor D.P. Singh, retired HOD, pulmonary medicine, and having so many other laurels to his credit, which he doesn't need introduction. Melanie Stevens and Professor Ravi Kirti. Melanie is a senior advanced nurse practitioner, a very experienced colleague in the NHS UK, and Professor Ravi Kirti, who is a professor of medicine at All India Institute of Medical Sciences, the Tertiary Center for Bihar. So, first question to Professor Singh. Professor Singh,
Yes.
let me let me pin you. Well, my question's about respiratory infections. Doctors running clinics till midnight for cough and cold, fever, etc. No one getting vaccinated. Medical vaccination, medics vaccination, hardly any. Healthcare workers vaccinations, hardly any. In Bihar context, I'm saying, despite an ample evidence that that if you can protect yourself and others. So, what do you think the scale of the problem is? And before we talk about the ways forward, when Melanie comes on, and we'll have some time for panel discussion.
First of all, thank you very much, Dr. Ashish Thakur, for inviting me, and my salutation to my mentor, Dr. Baby Thakur sir, the chairman of Indian Foundation, and congratulations to bringing this such a topic, which is very necessary, especially the beginning of the winter season. And usually we physicians think more about the disease continuum rather than wellness continuum. And that is the focus. We Indian doctors or people practicing in Bihar, very rush of patients are there. But we always think about the diagnosis of the disease. We always think about that how to treat the patients. But the prevention aspect, the preventive approach, the how to make the people well, because the best physician are those who can prevent the disease rather than treat the disease. That's the thing that is very much required. During the winter season, a lot of respiratory infections occurs, and we know for sure elderly people are much more prone to our Professor Dr. Eshanari talking about the diminishing immunity. And the infections, whether it is simple influenza, or even the pneumonia is so common, and even other viral infections that are very common, other illness that has been already beautifully enumerated by Dr. Ishmita Thakur. So they are there, but these elderly people are much more prone to that, and we should think about this preventive aspect much more than this, so that we can prevent the disease, so that the illness should not occur to it. So, and in that, even the doctors are not aware of that. So doctors, even they think they are afraid of injections. They don't think about themselves that they should be vaccinated for annual influenza vaccines or even the pneumonia vaccines. So if you take the data of that how many healthcare professionals they are vaccinated. So unless they feel like that they should be vaccinated first, how they will advise the others. And in Bihar, there are many problems, many challenges that Dr. Smita Thakur very well said, that this affordability of that vaccines, that is very important. And this lack of awareness that is there, not only in the doctors, but also in the patients. Accessibility. Just now, very nicely organized that camp that in the affordable price, the vaccine has been given. Resource allocation from the government side, that is also that is one of the problems. So we should think about the preventive aspects, and we should give importance data. Even the data, if you say what is the data of mortality of Bihar, there are hardly any data if we search in this. There is very scant that 2 out of 300 confirmed H1N1 cases that is there. Even in this recent outbreak of 2023, hardly very few data are there. Mortality is said to be low. But you know that worldwide there is very high figures are there, 2. Maybe 3 lakhs to 6.5 lakhs.
So can I ask you a related question on that?
Yes.
Because that's your field, your specialty, and you're an expert in that. You do run vaccination clinics on a very regular basis.
Usually this acute exacerbation of COPD, even this chronic asthma, we usually advise that even the hospital after the hospitalization, patient recovers during the discharge. Yes. Always advise that, and we have these influenza vaccines in my clinic. We have these pneumonia vaccines in my clinic, and usually this respiratory infection, especially this annual influenza vaccines, is very common. And people must know that annual influenza vaccines, why it is important. Even the doctors must be aware that because of that diminishing immunity in few weeks, few months or so, and plus this mutation of the virus. So annual influenza vaccine is very important.
Why do you think that the vaccination rates right now, currently as it stands as per the statistics which I have to hand in front of me, that is 0.2%. It could be one of the lowest in the world.
Yes.
Let alone talk about India or Bihar. But also in line with that, there's no government initiative on vaccinating the seniors, elderly, frail, or above a certain age, people with comorbidities. Yes, there are guidelines here and there.
Yes.
But there's no national drive. The national programs are more for, in vaccination wise, are more for children. So do you not see this as a big problem? And also some misconceptions about the vaccines.
Not a problem. This you know that we have to be awakened, and we have to set up this take up this awareness program by every forum. Not with the API, IMA, even the Hridayam Foundation has done the very right thing at the right time. But similarly, IMA should take up this program, API should take up this program, and we must make our healthcare professionals aware. You must advise this. Not every physician take the time and advise the patient that you must take the annual influenza vaccines or these pneumonia vaccines that William Osler said, the friends of old men. Because
and if I said that if you don't have the vaccine, you cannot do frontline clinical duties, do you think that would be a very big deterrent? Do you think that can ever be possible, that if you're not protected, you can't see a patient?
That will be very strong, rather than legal actions or something like that. But that should be the mandatory. Yes.
Right.
Unless you get vaccinated, you should not. Especially the older patient, older doctors. During the COVID, even the not vaccinated, they are treating the patients without any vaccination and without any precautions even. They are treating the patients, and they are not careful or not taking care of themselves. So that is careness or inertia of the doctors. That message should be strongly go to every listeners or every healthcare professionals, that you must protect yourself before you treat the patient, because I've already told you that the wellness continuum, that should be the message. The prevention should be the message, not the disease continuum, not
So
the
wellness
treating the-
continuum, starting
Yeah.
the vaccination from the medics first, only then the patient will trust you
Yeah,
and will
yeah.
have it, and
Yeah.
then perhaps then making some progress. So we will take I'll put you on hold and we'll move on to Melanie. Melanie Stevens, a senior ACP, National Health Service. She's got a wide experience of dealing with this particular issue. So Melanie, are you around? Let's have you on the pin. Welcome to the symposium. And can I ask to unmute you? And
right, I'm here, I think now.
Sorry. Yes,
I'm here, I think now.
We can hear you very well. So welcome.
Thank you.
And now my question to you is very, very straightforward and simple. You have a long experience. You can perhaps give some perspectives from the West, which the wider audience here and us can all take some learnings as to how we can perhaps push this agenda of vaccinating medics, healthcare professionals, not just doctors, I'm saying. At least the influenza one, if not others, or let's say pneumococcal or whatever's necessary, and then and going around this big barrier. We have lowest vaccination rates. The vaccines are freely available. They are expensive, I have to say. And there's been a recent change. I don't know, you must be aware that the WHO said that there's no need to have quadrivalent vaccine, and they have removed the need for having the second strain of the influenza B. And all the vaccines which are now being released in the market from this month onwards are trivalent. So 2 strains of influenza A, 1 of B, that's good enough. And that's what I've had the week before I came here. And in India, we have vaccinated today at least 25 people with the trivalent strain of vaccine which we were able to get hold of. So how can we work around this big barrier?
Thank you very much for inviting me to talk from a very cold and grey England. I'm sure you're a lot warmer over there at the moment. During COVID, I worked as a care home liaison nurse. So I watched COVID tear through our care homes and killing around 25% of our residents. And this was, of course, pre-vaccination. Post-vaccination, the deaths dropped back down to normal. So I'm a great proponent of vaccines, and I never fail to have my flu vaccine every year. But unfortunately, now we have a big distrust of not just medics, but big pharma. So there's lots of conspiracy theories, and indeed, even somebody very powerful in America currently is a bit of a vaccine critic. So it's very difficult to inform people of the necessity of vaccines. And it's getting the right information out there to the right people, isn't it? We do know from statistics that people from a poorer background and people from ethnic minorities in this country do not take up vaccines as the wealthy white do. So it's getting that information out there in a form that people can understand, and often utilising people that they will trust. So people may not trust a medic, but they may trust spiritual advisors. So it's often getting out to centres of worship and taking the vaccine out to people rather than expecting them to come to us. They will come to us if they were poorly, if they're in pain, if they're ill, if they want us to do something. But for a vaccine that's preventative and they may not see the point of it, we need to get it out to them, because if it's there in front of them and being offered freely with the correct advice, they are much more likely to take it. So getting it out here in supermarkets, into places of worship, into shopping malls, where people don't have to make any effort to get it, I think people are far more likely to take it up. But we need to get people from their own communities on board to spread the message.
That's very, very useful. And unfortunately, we have a lot of community organizations, a lot of NGOs or charities working, but I don't think so far the vaccination bit is has been integrated into the agendas, except for a few, who link into healthcare directly. And we take pride in doing that, to say that we've been doing this for almost 3 years now. However, we still have so many issues. And do you think that, like in UK, you have pharmacies, your nearby pharmacy can vaccinate you.
Yes.
If you're eligible, free. If you're not, then you can buy it and get yourself jabbed.
Yes, it's still quite cheap, the flu vaccine.
So do you think that it's a very big problem, or do you think it's an easy to overcome problem, provided you have a way where you can cascade, as you rightly said?
Well, our vaccine rates are still quite high in this country. I believe they're around 75%, although they are dropping very slightly year by year. So we are struggling with vaccine hesitancy, even when it's free and readily available in this country. So I still think it's really important that we get the vaccines out to people rather than expecting them to come to us. If we want somebody to do something, then I think we need to make it as easy as possible.
And one of the key things I wanted to say here at this point, that the cost of the flu vaccine, especially the quadrivalent ones like from Abbott and other companies, is almost the same what it's in England versus India.
Yes, I believe it's only around £20.
Exactly. So it's almost it's same cost here. So, and without a government program running, which would make eligible people eligible for free vaccination for those who need it. Do you see that we can ever, break the ground?
I think that will be a very uphill battle, because if £20 is nothing for somebody who's middle class and has money to heat their house and pay for food, whereas £20 for a very poor family in this country would be just be undoable, especially if you've got a few people in the house that would require vaccination.
Yeah.
I think what you need is the NGOs to get on board.
Yeah. So
and if the charities and the community workers can get on board with vaccination and provide those vaccinations for very little cost, I think then you would have a chance.
Yeah, on that note, I think there's been a release by a couple of companies together in the last couple of days that the trivalent vaccines are going to be at least £5 cheaper, but still their cost is going to be around £12 to £15. And in my clinic in the NHS, I've had patients who have refused to say that I'm not going to spend £20 on flu vaccine. I can't afford it.
No.
I'm not
and even
eligible.
those that can expect it for free, because in this country we have universal free healthcare, so people aren't always willing to spend money on
that. Right. So some community initiative involving NGOs or the non-governmental organizations, mobilizing funds from somewhere.
Yes.
We have a model where we, I'll give you an example how we manage it, to be honest, and that could perhaps you might say that's good or bad. So for friends and family, we offer them vaccines at 50% of the costs, which we get from the suppliers who are happy to provide that to us as a registered NGO or a charity. So that saves the cost for us as to buy. But the monies which come to us from our friends and families who can pay goes to our free vaccinations for our patients. So it's a way of flow of funds to do the same thing. And any shortfalls are picked by us. So that's one model which we've found which works, but it's a very small one, in such a large state. As you see, you're comparing 0.2% or less than 5.5% versus 75% in a place which is double the population of UK.
Yeah.
And with so much of poverty. and illiteracy rates as high as 80%, or rural population. So I think we are at crossroads. I would invite some comments at the end, but we need to have Ravi coming in now. Professor Ravi Kirti. Thanks, Melanie, for your kind
Thank you.
and very useful thoughts. Ravi, welcome.
Hi, good evening.
Nice to meet you. Nice to see you, actually.
And a very special pranam to all my gurus on the panel.
So, Ravi has been a colleague for a long time on the NHS before he moved to Patna, and Professor of Medicine, AIMS. Ravi, I'm going to ask you a very straightforward thing. As you know, you work in the most respected tertiary center of this state. How do you see this moving forward? You know, you must be dealing with so many complex respiratory, cardiorespiratory, multi-system issues, winter-related problems, admissions, where no one is vaccinated, multi-comorbid things, all sorts of stuff, government and tertiary initiatives to minimize this infective burden. How do you think that we can make some progress, especially for the seniors now, whether you call 60 plus, 65 plus, that's up to you, you know.
So I think the problem is that in India, we do not have a comprehensive vaccination program for adults as we have for kids. The universal immunization program for children is very successful.
Yeah.
And fortunately, we do not have any acceptability issues the way you have anti-vaccinators in the West. We don't have that kind. And maybe some isolated demographic pockets might have some resistance to vaccines or new vaccines, but by and large, people are very accepting. And we've seen this during COVID. We were probably one of the most successful countries in the world in terms of vaccination, given the scale of our population. So there's not so much of an acceptability issue. The problem is at policy level. I mean, except that we have vaccinated the entire adult population against COVID, and there may be some programs for very specific population groups like tetanus toxoid for pregnant women, or maybe yellow fever vaccine for people going to certain countries. We do not have a program to vaccinate our adult population, and that is the problem. I feel that the pediatricians are very vocal advocates of the patients, and you see new vaccines being added on to the universal immunization program.
But,
for example,
I'm gonna ask you a related question that, you know, that's directly linked to what Professor Singh and Melanie were referring to, that it has to come from the top. So if we are not vaccinated, I mean, it happened today actually. So two people who came and who were eligible, and they were being offered free vaccine, said no. The moment we said that this is going to do this is going to do this, there was an instant acceptance, and there you go, job done, as you rightly said. So the acceptance way or methods could be different, but I think the way to convince is easier. I think it's a bit more in the literate society than people who are less literate. They would listen to your advice. If perhaps cost is also a factor. If you tell that you're providing it free, they might accept it straight away. Do you agree?
To a large extent, yes. And maybe there might be a little bit of apprehension when it's coming from an NGO, but if it was coming from the government, if it was in the national policy, it would be even more acceptable to the larger sections of the population. What I was trying to come to is that, I mean, the elderly population is actually just the top of the pyramid. So given India's demographic profile and that we're such a young nation, if we had a very selective group of population that we could identify who should be offered the benefits of vaccination against pneumococcus plus minus flu, I guess it's not going to be that big a deal in terms of, I mean, relatively not big, not such a big deal in terms of finances, because as has been pointed out, our elderly population is much smaller compared to the bottom of the pyramid, the kids and the younger people. So I think it's a matter of somebody making a case to the policymakers and doing a proper cost-benefit analysis and getting the policymakers on board. So that job needs to be done by our professional bodies, and we should take some cue from our pediatric colleagues in the way they advocate their cases.
Thank you, Ravi. That's a very, very nice, nicely summarized views and thoughts coming from you. It's interesting that I read that Patna city, which is the capital of Bihar, has the highest number of elderly people in the state. Any quick comments on that before we wrap up and invite one or two comments from the rest of the panelists?
So one, it's a densely populated city compared to the rest of Bihar. So obviously in absolute numbers, the number of elderly would be large. If we were talking in terms of proportion of the population, I guess because a lot of people move out to work, and probably in my generation, there was an entire generation that left the city to work elsewhere. So, and their elderly parents are left behind. So there's a large number of such people in the city whose children and grandchildren live elsewhere, but they have retained this place as their place of retirement. So that's my speculation.
Thank you. It was headlining in Times of India. That's 75% of elderly population in Patna may require home care. Anyway, on that note, I would ask Professor Singh and Melanie to give any final comments before we wrap up this session. Any comments from Dr. Singh or Melanie, please?
I'm sure Dr. Singh is right that it does probably need to come from the top down until you have a comprehensive vaccine program from the government.
Sure.
Then yeah.
Agreed. Yeah. Professor Singh, Dr. Singh, any quick comments? Dr. DP Singh, are you on, sir? Right. Okay. So we're on time, and
may I make a quick point about something else that?
Yes, please. Yeah. Just a quick one, please.
Yeah. So this issue of blood pressure going up in the winter, probably one of the things is our high salt intake. We generally take much more salt than other parts of the world. And while in the summer, we lose a lot of it in sweat, in winter, we don't do that. So that's probably a message that we should give to our patients, elderly people, and everyone really, to cut down on salt intake in winter.
That's a very, very valid point and a good take-home message. Thank you so much, Robbie. Let's close this session. Smita, you've raised your hand. Just a quick one.
Yeah, very quickly, I think Melanie and Karuna, you'll appreciate, because our flu uptake was so low, and come pandemic, and people thought, let's take the flu, COVID vaccine and the flu vaccine, and the uptake went up, even though it's free. There's a national immunization program. So the vaccine hesitancy is a big issue.
Thank you. I'm sure we will be making some ways forward in the coming months, years, with collaboration of all the national state societies and community. At least we made some real progress, which I personally feel so far. Thank you so much, Smita, for your very nice comment. So moving on and changing track a little bit and coming to some real another important stuff is our next theme, which is linked into musculoskeletal health, which is maintaining body strength in winter. What are the challenges and opportunities for seniors? So can I invite Liam Hines? Liam, are you logged in? Liam?
Hi, yes, I'm here. Can you hear me?
Oh yeah, Liam. Yeah. Hi, Liam.
Hi, how are you?
So Liam is, just to introduce him quickly, he's one of the highly skilled and experienced musculoskeletal physiotherapists in the NHS UK. He's an ultra marathoner who's an inspiring figure, and I'm grateful to him to have accepted this invitation to come on board and give us, or not just us, but the seniors in the group, some really good insights into maintaining body strength. And besides that, we have Dr. Manish Kumar, President of Bihar Society of Rheumatology, and a good and a fantastic colleague, Mr. Shetty, a senior consultant surgeon. So over to Liam before we go on to the other ones. Thank you.
Thank you, and thanks for the invite. I'm just going to share my screen quickly, doing a little PowerPoint, and can everyone see that?
Yes, it's visible. Thank you. Go ahead.
Lovely.
Yes, we can.
So just going to do a little talk on physio guide on how to stay strong over winter. Make it nice and simple. I'll go through different bits. So key themes of today is going to be aging conditions. It's going to be nutrition, understanding the why. So always, why are we exercising? Why are we doing something? Helps our patients understand what they're doing it for. Often helps general uptake of it. Common misconceptions of physio exercise. And then we're just going to go through some key exercises over winter that can be useful for maintaining strength. So first slide is going to be aging conditions. I'm not going to go through these conditions in detail. I hope most of us come across at least one or several of these conditions in our patients, but hypertension and osteoarthritis, very different things, but they're linked by a couple of things. The first being obviously age, and then from there, there's one thing that links to all of them, and that's exercise helps them all. So it has massive benefits, which is lowering blood pressure, reducing stress, improving weight control. It strengthens the heart, the muscles, the bones, improves lung capacity. The list goes on. I could talk for hours on the benefits of exercise, but all of these conditions can benefit from it. And often what most people don't understand is when we're trying to do things such as lose weight, exercise is actually a small portion of that. The main thing is going to be nutrition, and it's understanding what types of nutritions are good for us. So spices like turmeric, garlic, ginger, black pepper, that they all help fight against colds, infections. Whole grain foods such as wheat, rice, bajra, jowar, they can all help provide energy to keep us warm. Hot drinks, hot clothes over the winter months will help keep us warm, fight against colds. Proteins are going to help maintain muscle strength. That can come from eggs, it can come from milk, chicken, lentils, various sources. We don't often see the sun over the winter months, especially if we're going to work or it's too cold to go outside. So vitamin D levels drop. How can we look at increasing that? Well, that's going to come from more seafood-based products such as fish. It can be in eggs as well. And that's essential for maintaining immunity, bone strength. Vitamin C is really important as well. If we're looking at it can be found in oranges, watermelons, tomatoes, green chilies. And then the two biggest no's really are going to be alcohol smoking. I'm never going to say don't drink, but it's drinking in excess and smoking. Well, both really are two massive causes of global body inflammation. And when we're looking at a lot of chronic conditions where you've got an inflammatory aspect to it, whether it's a byproduct or it's the main thing, by reducing these, we can see a reduction or a complete reduction in pain levels and general improvement in our patients as well. So it's just trying to get the bad habits out. Then understanding the why. So for a lot of joint conditions, I'm going to talk about away quickly. We know that heat can be really beneficial. It's a lot cheaper than things like medication and is readily available throughout the day in the house. Or it doesn't have to be necessarily a hot water bottle or a cup of tea. It can be warmer clothes to keep your joints a little bit warmer, making sure you're moving around a little bit more because we know movement generates heat as well. And that's why the next slide is movement is medicine, because the more we move, the healthier our joints, our muscles, our bones can be. So away often activity slows down away progression. Inactivity can speed it up. So the more that we're sat down, the more that we're laid in bed, a lot of these conditions can get worse very quickly from this. So movement helps strengthen the joints, it helps strengthen the muscles, improves bone density. And by having stronger muscles, you can have happier joints because it reduces the load of a joint. For example, if we're talking about OA in a knee and we're aiming to strengthen the quads, then the quad muscle offloads a lot of the stress through that knee itself. And then I've put there as well, just to be guided by pain, not stopped by it. Just because we've got pain on our knees, pain in the hips, pain in the back, doesn't mean that we shouldn't be exercising. That's even more reason to exercise. So it's just educating the why and that pain shouldn't be the limiting factor as well. And then moving on to common misconceptions. So for a lot of people, this is getting better, but they essentially thought physio meant massage, which a while back probably was the case, but that's not the case anymore. I can't remember the last patient that came through the door that I gave a massage to, essentially, where often now, from looking at the evidence, it's exercise that's going to help these patients long term. Massage can help you feel better at the time. It might be a 5-10 minute, oh, I feel great, but then after that, the pain's going to come back in quickly. Whereas if we're using exercise as an adjunct, that long term is going to help our patients improve a lot more. And it's our job as physios to kind of understand the barriers around exercise and then to help you work around that. So if you can't go outside because of the weather or because there's nowhere to go for a walk, then using something like a step up and down for a minute, have a rest, do it for another minute, have a rest, do it for another minute. It's just little workarounds like that. And then in physio, we often work with pain and with people in pain, and people can have a bit of a preconception of physio's painful, exercise painful. It doesn't always have to be. A lot of the time, we're trying to actually offload these painful structures, reduce people's pain, and it's only in specific cases where I'm probably going to tell someone to actually push into pain to help get movement back in a knee or a shoulder or whatever it is. It's not that often that I'll actually probably have to go through that. That leads nicely onto pain is gain. We had a massive wave of elderly patients coming through saying, I have to push through pain to get through this. We know in chronic conditions that's not going to be the case. It's only more likely going to cause more acute flare-ups. This could last for days, it could last for months. And especially if it's lasting for weeks and months, then that's going to lead to further deconditioning because they're unable to do things such as simply get out of bed and go for a walk or get out of bed and get down the street to the shop. And I often hear the words arthritis is wear and tear, nothing can be done for it. all the time. And we know OA is a natural aging degenerative condition. It's a joint that's become a bit unhealthy, is how I often describe it to people, because wear and tear sounds like something that is grinding against each other, and we know only in like really severe cases is that the case. Often these are patients with really mild or moderate OA changes, but with exercise we can help slow this down, slow this progression down a bit more. So it's just trying to get that message across to patients as well. So going through a few key exercises. One of my favorites is going to be a lateral raise. So this doesn't have to be with weight. It can be with a water bottle. It can be with a bag of rice, anything, doesn't matter. But this exercise hits pretty much every single muscle in your shoulder, and helps strengthen them that way. You can progress it really easy by using something heavier, doing for more sets, more reps. A wall push-up is really simple. It can be done anywhere, and is often made easier by making the gradient steeper. So going to a table first, then maybe going to the floor. If you get to that point, you can go onto your knees as well. And then using lumbar flexion and good mornings as a way of strengthening lower back. And this is often a movement that's quite painful in patients with lower back issues. So it's just taking them to the point that they're comfortable with, taking them back. They can add weight if they're really comfortable with that, and they can go all the way down. That's fine. But again, when I say weight, it is small water bottles, it's bags, it's working your way around it, because we're not expecting all patients to have access to dumbbells, kettlebells, and things like that. Even in the UK, not everyone's going to have access to those. So from an upper body perspective, that's what I'd usually recommend to start off with. And then moving on to lower body. I mean, how often do we do a sit to stand or a squat during a day? We do it all the time. But if you now do that 10, 15 times, that all of a sudden becomes a lot harder. And even more so if you add weight. Calf raises, really good for strengthening the calf. Add weight to progress it. Go on to single leg to progress that even further. We can regress that even further actually by sitting down and doing the same thing. So lifting up on tiptoes, getting your heels off the floor. Single leg balancing is really good in terms of getting good pelvic control, getting the glutes involved, but also in helping improve balance, reduce the risk of falls. But you just got to make sure you've got something in front of you to hold on to, essentially, because it doesn't matter how old you are, there's always going to be that slight risk in falls. And we know in our elderly population, a simple fall could lead to multiple fractures, wrists, pelvis, and that leads to even further degeneration. And then the last one I'd like to come to is one that I do a lot of in physio, and this is from 18-year-olds all the way up. It is a bridge. It sounds really simple, but there's lots of different ways in the way we progress this. So a bridge is really good for pelvic control, glute strength, hamstring strength. But you can add, at the top, you can add a little leg lift to bias one side, and really emphasis the control on that side as well. And this has been linked to help improving balance and maintaining control as well. So thank you for listening.
Thanks, Liam. That was very comprehensive, and I'm sure some of those simple exercises would help all of us. Actually, the only thing I wanted to quickly ask you that, when all the standing exercises where someone is struggling with balance or knee issues or hip issues,
yeah,
it might be okay to hold on to something and
absolutely
still be able to do calf raises, still be able to do all that, which puts some pain and strain. Or one should not challenge that, no, I have to somehow do it without supporting myself.
Yeah, it's making sure you're in a safe environment a lot of the times, isn't it? And then sitting is often one of the ways that we're more comfortable doing, and often for a lot of people can be pain-free. So it's making sure you're doing it in a safe environment, safe position, that is comfortable for you.
And the last question perhaps I have for you is, do you think that everyone should have a bespoke senior, MSK, musculoskeletal plan with a discussion with somebody like yourself or a local, they're locally available physiotherapists?
Yes, I mean, this would be the ideal world, wouldn't it? But unfortunately, we don't live in an ideal world. But I mean, having a chat with somebody would be the starting point. Going through exercises with them as well. I mentioned pain, and it's just making sure you're listening to that, making sure you're not pushing too far through it. I don't think it necessarily always has to be bespoke to yourself. You can do generic exercise classes on YouTube, and if you're struggling with an exercise, you miss that one out and join in on the next one. So it's using the resources that we've got available to us sometimes to get around if we don't have access to a healthcare practitioner, for example. But if you keep consistent, you do it regularly enough, then you can see progress.
Thank you, Liam. Thank you. With that, I'll move on to Dr. Manish Kumar, consultant rheumatologist, President Bihar Chapter Rheumatology, as introduced before. Manish, are you on? Dr. Manish Kumar, I can see you. You have to unmute yourself.
Okay.
Right?
Hi, sir.
Hello, Manish. Welcome to this symposium. You've been listening to the to Liam's talk, and linked to that, I think my question to you is pretty straight. That it's changed. My thoughts have changed slightly as we progressed through the session, and I think limitations in multi-comorbid seniors. You've seen or so much of clinical limitations where people can't exercise, they might be bedridden, they may have given up mentally, and osteoporosis in particular. And rheumatology services linking into all this bigger cities rather than outside. Where do you see all this together as in your role as a president of a state society?
Good evening to all.
Thank you.
As a rheumatologist, I feel that it's not the responsibility of rheumatologists alone. It's the responsibility of the medical fraternity in general. That patient going to cardiologist, patient going to endocrinologist, patient going to rheumatologist, gynecologist, orthopedician, they should all be aware that any patient, female patient or male patient more than 65, they should be screened for osteoporosis. And if they are not able to treat or tackle the established osteoporosis, then they may refer the patient to the competent doctors. The first point is that they should all be aware, they should all be sensitized how to screen that whether patient is having underlying osteoporosis or not. For me, it's just a routine part that whenever I treat even younger patient, more than 30, more than 25, because in rheumatology, most of the patients are younger than 50, or the connective tissue diseases are occurring in the younger age group rather than older age group. In my practice, whenever I see a patient, there is a criteria that we are starting the patient on a steroid, and patient you are expecting that the steroid dose would be continuing for more than 3 months, and the steroid dose is around 7.5 to 10 milligrams. We straight away start prophylaxis. Along with vitamin D and adequate calcium, we start prophylaxis in the form of oral bisphosphonate. And the thing is, and as per criteria, established osteoporosis, we have to treat. And in elderly patient, as they come to me, like patient more than 60, more than 70 with established osteoarthritis, knee or hip joint, I screen those patients for underlying osteoporosis as well. It's part of my treatment plan.
Right.
Anything
Thank you so much.
specific?
So linking into that, we know that, our, let's say, senior population is about not that much compared to other
Right.
states. However, 80% of them are rural. This is data, very latest data, which is from 2023 caste census in Bihar.
Right.
So where do you see this disparity of seeking a proper opinion or even being aware of bone health?
Yeah, that's true. That's true. That's why I'm saying that it's a responsibility of every existing medical specialist, not only one specialty, rheumatology or orthopedics, and they should be, because they are catering all type of patients, whether they are rural or they are urban. They should be sensitized, but they should be screening all those patients whosoever are they coming to them. It's not possible to go to the village and screen every elderly population.
Sure.
It's not. But what we can do is, whosoever are coming to us, we should be screening them.
Right, right. Thank you. I'm sure that under your leadership, there would be certain initiatives which might improve this perspective
Maybe. I hope so.
in the coming
I hope
year,
so.
and we are
And
more than happy
another
to-
part is that whenever we are doing some screening part of, supposedly I arrange a camp with peripheral part and do some osteoporosis screening by ultrasound method. That ultrasound method is crude. It's not representing the true underlying disease burden or true osteoporosis. We cannot extrapolate it to for therapeutic part. So, and we cannot bring or take dexamethasone to the peripheral camps also.
Sure, yeah.
So whenever patient, you have get the chance to screen the patient, whosoever patient are coming to us, and if they require the screening for underlying osteoporosis, we should always carry it out. And for a poor patient, I would say that whether DEXA or no DEXA, with just a lateral X-ray, lumbar spine is good enough. It's called poor man DEXA. We can see the basing, we can see the status of bone in one X-ray only.
Yes, the take-home message from your fantastic quick thoughts are that heightened awareness, penetration into peripheries for all those who are seeing patients of all kinds.
They
and
should be sensitive.
a simple lateral lumbar spine X-ray
Is
can
good enough.
perhaps give some indications as to what needs doing, and
Right.
having some more education around that.
Yes, that's true.
Thank you very much. Thank you for your time. And we'll just move on to Mr. Shetty, Ajit.
Hello.
Welcome to the session. Ajit's a senior consultant orthopedic surgeon in the National Health Service, UK. I don't know how many hip and knee surgeries. He's always in the theater when I try to contact him. I think I sent you a question, didn't I?
Yes.
So what do you think about this this bit on trying to see winter as a bad time for bone and muscle health, and falls and fractures, and people having acute problems on pre-existing chronic conditions which could have been sorted out before. So are we doing things late and leaving us to risk in the winter, and then getting things done acutely, like acute hip surgery, blah, 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 where this could have been sorted out in an elective scenario if there was a problem?
So, yeah,
do we
thank
leave
you.
it too late to decide?
It depends on what condition we're treating, really. Now, in terms of joint replacement surgery itself, whether you should have surgery during winter or summer, the answer depends on where we are talking about, actually. In the UK, as you know, we don't differentiate between summer or winter. I mean, we carry on with the joint replacements, even if it is peak winter. But the conditions may not be ideal, as Smita has already pointed out. In some parts of India, it may not be ideal because if they have a cold environment and they do not have enough support, it is not an ideal time to have major joint replacement surgery. So the answer, I think, would be there are a lot of logistics to consider in India. I mean, I know friends and relatives who have contacted me and said they need a joint replacement. And the more recent example is a patient who traveled all the way from Manipur to Delhi, lived with a sister, with her daughter there. Son traveled from UK to Delhi to get a knee replacement surgery done. So there are a lot of logistical issues which need to be sorted out, which will decide the timing of surgery, unfortunately. But ideally, it will depend on the symptoms and if it's indicated and if the conditions are favorable, then it is fine to have surgery in winter as well. Now, there is a question of prehab. I mean, maybe we should think about it more often. The patients get deconditioned while they're waiting for surgery. So it is important that they continue with exercises as best as they can until they have the surgery so that the rehabilitation is quicker. So, yeah,
thanks for that. I think a quick comment that there is very little pre-assessment in an elective manner. It all happens the day or 2 or 3 before surgery.
That's right, yeah.
Do you think that's the right way to approach it?
No, I think that is a problem, mainly because of the logistics, I think, in India. I mean, even the example I just gave you, the patient traveled from Manipur, came to Delhi, and just had the tests a couple of days before the operation. It is too late to treat anything. So if for example, the HbA1 is high, what do you do? Do you cancel the surgery? If the hemoglobin is low, do you cancel the operation, bring them back again? So the optimization for surgery should happen a few months before the surgery, which would be ideal. But is it always possible? I don't know. Sometimes patients just take a chance and say, yeah, I'll just go and see what happens.
Right. And do you think that there are more falls and fractures happening on this side of the continent compared to the West? I mean,
in terms of the statistics,
I mean,
considering the population and also the demographics, there are less elderly patients in India compared to the UK, proportional. The demographics is different. So the fracture neck femurs, hip fractures are certainly a lot more in the UK. That is just because of the demographics. Otherwise, I think it would be probably comparable, considering the population.
Well, thank you. I think this was some focused questions which might give people some real thoughts to consider. And if I'm correct in thinking, the point you were trying to make was it's not just the surgery itself, it's about preparation for good few months and weeks, and then the post-operative period, which is the most crucial time. So there's a lot of logistical thing as you cited an example.
Yes.
Thank you very much. With that, we will close this session promptly at 4 o'clock UK time, 8:30 India time. Moving on to our last theme for today, which is more on holistic health in seniors and trying to summarize it in a way where we have some take-home lessons, and time permitting, we might have some discussion from all the panelists who are still logged in. So let's have Dr. Deviram, who's leading this session. Dr. Deviram, can you unmute yourself, please? Please unmute yourself.
Can you hear me?
Yes, we can hear you now, sir. Thank you. Welcome to this symposium.
Thank you, Ashish. A
My
very
question
good
to you.
afternoon.
My
to
question
all
to
the-
you, sir.
Yes.
What are the top 10 tips? You're a very senior elderly physician, cardiologist, diabetologist, all in one, philanthropist. You don't need introduction. However, I have to say all that for those who don't know you. Top tips for holistic elderly well-being in the winter months.
Thank you, Dr. Ashish. A very good evening and afternoon to all the learned participants. At the same time, I wish a very happy Dhanteras when you pray the Lakshmi for wealth and God Dhanvantari for health. So this is a very proper time to have this webinar, which is on winter and senior persons, which is very important. But luckily, we in India are very lucky on this particular topic, as with global warming, in most part of India, we are left with only a few weeks of winter. In fact, we are dying to have some winter in India, at least in Bihar, UP and Delhi, but it is just a couple of weeks only. Most of the things which I was thinking to say has been covered directly or indirectly by many speakers. But my main opinion and the message which I want to give, that maintaining mental health is rather important for elderly. The elderly in India are facing a unique problem. I have just been to UK for 6 weeks. There the elderly, if not looked after by their sons and daughters, there are proper system of home for elderly and health visitor and etc. etc. In India, we are neither east nor west. Many people are deprived of family happiness. The sons and daughters are not looking after, or they don't have one. So my first feeling is that maintaining a good mental health for elderly is very important. They need to stay connected with their family and society. Get involved in as much as possible in social works. Go and visit your sons and daughters or invite them. Make a group of elderly or would-be elderly where you can thoroughly enjoy it. We in Purnia, in different platforms, at least we spend 25% days in meeting each other, which gives personally to me great pleasure. It happens all the way there, but in winter, when the day is short and the nights are bigger, elderly living alone are having a lot of problems. So I would advise that they should take care of that. Another thing that probably has been mentioned by other speakers also is focusing the nutrition and staying hydrated. It's very important. In winter, there is not much desire to drink as compared to summer. But I've seen in UK, people having bottles, they measure the water and they drink. They include other drinks like green and herbal teas and soup, etc., etc. And many of them calculate how much they are drinking. Unfortunately, neither I am doing it, nor most of the elderly are doing in India. So even if you don't feel thirsty, one should make habit of drinking water and these items which I have just mentioned. In Bihar, we enjoy the winter by having khichdi, chokha and papad and ghee. How healthy this is, I don't know, but I practice it. And garam, hot kheer. One should have nutritious, balanced food with a lot of protein and take a lot of fruits, antioxidants, vitamins, particularly vitamin D, and sit by sunny window or go for a walk, preferably within your own campus.
I must interrupt you for 1 second for my audience who are from UK and perhaps might not be aware of what you were referring to as enjoying khichdi and papad in winter. For Melanie, Liam, and a few others, it's basically a balanced nutritional stuff, which is basic rural food, which is made of rice, lentils, and some lentil-based, you could say, papadum type stuff, which
and pulses.
A balanced nutritional thing, which he was saying that this is what a lot of people would survive on and enjoy, and that's all the main meal for them in winter months, besides vegetables which are grown. Thank you, sir. Sorry to interrupt you.
No, not at all. Most welcome. Of course, staying active, it's a mental block here, I would say. People start feeling old. They don't want to walk. They don't want to move. They don't want to work. They ask the servant or domestic staff to do everything for them, get a glass of water, get me tea. After eating, they will leave their plates on the table. Somebody else has to do it. So these are very little things, but in my opinion, very important. If you do it yourself, being elderly, probably your muscles will be strong, your circulation will be better, your joints will move, rigidity will go down. But richer the people are, I'm not saying about all, less they do, which is unfortunate. Again, protecting the skin is another problem. In winter, it goes dry and thick. And funnily, many people are using Dettol soap, neem soap, soaps, this type of thing, which makes the skin even more dry. So my advice is that right and left, you get in the market lots of moisturizers, or if not, use the coconut oil, or use the soap, which probably is not that alkaline. And this problem I see almost every day in number of elderly patients in my clinic, and I'm sure others are doing also. Taking care of the chronic diseases, particularly hypertension. I'm not sure how many of you will agree, but I do see the blood pressure going up mildly or bit more than mildly in number of hypertensives in my practice. So that should be taken care of, and they should reduce the salt intake. And another thing which is important is this flu vaccine. We, as a doctor, the patients, are not educating people to get the right flu shots when they need it and when it should be given to them. I heard one of our learned speakers talking about it. Again, staying warm and safe, having proper heating, etc. These are the common things which one should not neglect. And elderly should be more careful in nights in case there is no light, which is not very unusual in Bihar and UP. They should have some emergency light system. They should have some system when they can take care of not falling and not fracturing themselves. So these are very trivial, but in my view, very important.
Sure, sir. Thank you so much. I think that's a very, very holistic view. I think we have a poster which I will share in the chat box as a summary of well-being, holistic well-being in winter as we go along the way. But I must now invite Professor Dr. Rangila Sinha, who also doesn't need any introduction. She's been Professor and Head of Medicine and of Ops and Gynecology at the SK Medical College, Muzaffarpur. I apologize, along with having so many other roles. The idea of welcome, Dr. Sinha.
Yes.
And it's lovely to have you this evening, and thank you for coming on. And the questions is very specific, that do you see that senior or elderly or whatever, we've had a long discussion around the age cutoffs, that. Is there any difference in females versus males, which you have seen in your very long and distinguished career? And does gynecological issues, which kick in with age, and menopause, which kicks in slightly earlier than that, perhaps contribute to that? And how does winter link into all this? I know it's a complex question.
Thank you, Dr. Assis. I very much appreciate your patience and your performance from very beginning, and especially today I have seen. So far, general information and precautions are concerned. So these things were repeated by so many speakers. You have asked me that is women different in some way, especially after menopause? Yes, the women are having two disadvantages. One is what is with the general population, and another is being women, they have got special organs, that is ovaries and uterus. The ovaries secretes a special hormone, estradiol, which is very important for keeping the women as women. And once after menopause, when all the primordial follicles, when the follicles have exhausted, then there is no estradiol. And so all the advantages of that estradiol has gone. And now the women have special disadvantages, that is, of being women and have this special organ. So after, in elderly people, after, not even elderly, I will say, after menopause, because menopause starts, the average age of menopause in all over the world is 51. And that time it is quite young, it is middle age. And then that time there is deprivation of this estrogen. So that deprivation of estrogen carries on a disadvantage on different organs, especially on the genital organs and the bone systems. So gradually there is a loss of bone mass, and these women are more susceptible to osteoporosis and related symptoms with osteoporosis, backache, pain all over body, in joints, especially the backaches. So all women, almost I think more than 50% of the women after menopause, they suffer from backache and require a special type of massage and medical and then Ayurvedic treatments throughout their life. So this is bone loss and osteoporosis is a special disadvantage with women. And for that, the precaution is that fall is very important in these patients. And another disadvantage is that there is generalized dryness of epithelium, and especially of genital organs, vagina, urethra, lower part of urethra especially, and skin all over. So this degeneration of epithelium causes senile vaginitis, senile urethritis, and itching all over body. And as a result of that, they have to get up from bed in the night for frequent micturition. Because there is urethritis, it appears that there is a UTI, but it is not actually UTI, but it is due to loss of estrogen in that last part of urethra, which is dry and degenerating, and that gives the irritation, and this causes frequent micturition. So especially in winter season, I advise my patients to take less water, especially late in the evening, so that they have to get up less in the night, and they have to get out of the comforts of their warm bed and then go to toilet, because toilets are not that warm in India, I think, in comparison to bedroom, that most of the houses that bathrooms are not that centrally heated. So these are the special things which the women has to face, and there is generalized itching. For that, some women has to take antihistaminics, and that antihistaminics that cause giddiness, and that is another factor which causes fall, and there is increased incidence of fall. So in these ways, these women are more in disadvantage, and they need a special care during winter. And I don't agree with Dr. Ram that there is no winter. Sometimes the winter is so severe here that what clothes I used to use in Scotland, that I have to use here. So winter, sometimes it is extreme of weather here. Either it is too hot or it is too cold. So this is a special thing about women which we have to take care of, apart from the general precaution for all population. I think this is the answer of your question.
Yes, ma'am. I think that
I want to be short because everybody is tired of the long discussion.
No.
And
I think you've kindly I think hit the nail, quite how we thought, or how I thought that you might deal with it with your extensive experience.
So how these symptoms should be treated, I will say that due to senile vaginitis, there is pain, dyspareunia, dysuria. All these things has to be treated with local estrogen cream.
We always worry that why women, especially in this part of the continent, also in my practice where
I can't hear.
In our practice in England, we have a high incidence of early osteoarthritis in Asian women after menopause compared to
osteoporosis, more chances of osteoporosis.
This is why,
because less intake of calcium, poor diet. Apart from, because there is enough heat, sunlight, so there should not be more osteoporosis. But I think it is poor diet and this is more women are more confined to home.
Sure.
They don't go outside. That might be one reason. And that osteoporosis is common in all women
Well, thank
because
you.
of this estrogen. Estrogen factor is always there with every women. But this more osteoporosis in Indian, why it is? It might be poor diet, most probably.
Thank you. Sex-specific factors, apart from age-specific factors, linking into this together is the take-home message from Dr. Sinha's wonderful
Age is one
deliberation.
factor in getting osteoporosis, but lack of estrogen is another factor.
Yeah.
Which
Thank
is
you.
added in women. And that's why women have more osteoporosis and more osteoporotic related fractures than men.
Right. Thank you, ma'am. Thank you for your very, very kind and very, very knowledgeable words, which will, perhaps enlighten the audience as take-home messages. I think to finish off, I've invited Karuna Sharma, a senior NHS general practitioner, to try and summarize in a holistic way and also perhaps throw some light on community side of things as to how we could perhaps improve elderly or senior health.
A very good evening to you all. Can you hear me?
Yes.
Yes.
My heartiest regards to all my seniors. Thank you, Professor Ashish Thakur, for inviting me to speak along with all the super icons of our medical world. I think most of the things for winter preparedness for our elderly care has been covered. I would just like to highlight a few extra things. So here, other than the preventative steps like vaccination against flu, pneumococcus, shingles vaccine, we also put patients on prophylactic antibiotics for patients who suffer with recurrent UTIs or recurrent chest infections, depending on their individual medical condition. To some patients, we also arrange for emergency rescue pack medications like antibiotics, oral steroids, so that they can manage their acute exacerbation in the best possible way. Preparing for winter is the key for this cohort of patients. I agree with Dr. Manish Kumar that the medical care for a particular patient is not just the responsibility of one healthcare professional or just the patient, but that goes beyond that, and everybody involved with patient care, like the patient, relatives, neighbors, carers, and all healthcare professionals, plus some charity organizations, they're all responsible for the patient's care. And to that end, I would advise that as part of the winter preparedness, the patient should have an assessment to make sure that they have got enough occupational health review to make sure that they are not at increased risk of falls, their blood pressure has been checked, their diabetes is under control. Are there people around them who can keep an eye on their hydration, as it was mentioned by our previous speaker? I have come across several patients who needed hospital admission with acute confusion due to dehydration, suspected AKI. All those things could be easily prevented. Are their homes safe and secure, particularly for the patients with dementia? Again, I came across a couple of patients who were found to be wandering in the streets in the middle of the night, brought home by police officers after they were alerted by people there. A couple of my patients, they were also hypothermic. One had escaped in the garden of the care home, and one again was wandering in the street, very, very hypothermic. So these are the things that need to be taken care of to maintain good health for that category of patients. In my surgery, we also code certain patients under special code like code 300. And what that means is that when these patients or their carers contact us, we address their concerns on an urgent basis to prevent further exacerbation or hospital admission. Here we do have advanced care planning system. I don't think we have got equivalent of that in India, but something like that can also help healthcare professionals in deciding patients' preferences and their management. We do have national and local charities in UK like Age UK, British Red Cross, Royal Voluntary Service. I am aware that there are voluntary organizations in India as well, but I'm not 100% sure what is the extent of the charity involvement in Bihar, and I would like somebody to please comment on that. Medication review, deprescribing, these are again quite useful tool to help maintaining good health in winter. Treatment at home, we have hospital at home teams who get involved with patients who either do not want to go to hospital or should not go to hospital, that can easily be treated at home. And that is really, really useful. One thing I personally struggle with, I'm sure that is a national problem, when patients are discharged from hospital, sometimes we find that the discharge summary is incomplete, incorrect information, not enough medication were given to the patients, and the care package that should have been in place are not put in place. Patients with catheters are discharged without proper catheter care in the community. So these are the things that we need to look at and rectify. There should be step-down services before they are discharged home, particularly if the patients live on their own. For some patients, if they know about the benefits available to them, that can help them cope better in winter, like pension credit, attendance allowance, carers allowance, council tax reduction, and cold weather payment. I'm not sure, again, what equivalent benefits are available in India to the senior citizens. So again, I would like somebody to please comment on that. Safety checks at home, like the fire alarm, smoke alarm, carbon monoxide alarm, because in winter, some households still burn wood and coal. So that can be a risk factor. So that should be taken care of. Whether somebody who is looking after those elderly patients, do they have first aid kit in their house? Do they have their medical cabinet stocked up for the winter with things like paracetamol, ibuprofen, dressings, plasters, cough mixtures, and things like that? Do they have common household medical gadgets like a thermometer, pulse oximeter, blood pressure monitor? I would say smartphone. I know smartphone is not very popular in the elderly group, but I consider smartphones as a medical device, because many things you could do with a smartphone for which you don't need a proper consultation, and you don't have to depend on someone for you to take you to your doctors. For medication delivery, do they have a designated chemist? Do they have dorset box arrangements? Do they have home delivery services? All these things can improve their care quite a lot. There could be many more, but I think if we concentrate on even these points, they can be better prepared for winter. I think Dr. Thakur had asked me also to comment on homeless people and also the mental health in elderly. As it was rightly pointed out by the previous speakers, that winter is not good months from mental health point of view in the elderly patients due to loneliness, due to isolation. So we do have some charity organizations who can help in UK. We do have a 24/7 telephone service called the Silver Line Helpline, which people can help. So the bottom line is, do they have written information with all the contact details at hand, just in case they need help? That would be a great help and support for them. Do they know how to self-refer themselves to the counseling services like Talk Plus? And obviously, if their mental health is deteriorating, then they can contact us and we can refer them to the community mental health services, where they can be assessed by a team of consultant psychiatrists, registered mental health nurses, occupational therapists, speech and language therapists, and the psychologist, and they can have a care plan in place which can help in de-escalating the situation getting from bad to worse. Coming to the homeless people, that is a problem in UK. Obviously, the homelessness is the problem of the social services in that area. But in the medical context, it is also our responsibility. And according to the current patient registration guidance, they do not have to provide us with a proof of their ID, an address, or their immigration status. To help that sort of patient, what we do at our practice, we allow them to use the surgery address to get registered and also to receive hospital correspondence until their address is kind of sorted. We do also have some charities who can help the homeless people. At my surgery, we also do collect some donations and donate to the charity for the homeless people, so that like some certain festive periods, they don't go without food, clothing, and whatever else they might need. I will stop there, but I would like to thank you, Professor Ashish Thakur, for the invitation. Thank you.
Well, Karuna, that was a very, very holistic and nice talk, summarizing things which perhaps I put to yourself in not one, not two, but actually different ways. So this is literally, guys, the end of the session. Dr. Devendra Bhushan, Secretary, Bihar Chapter API, is taking an excuse. So it is my duty now to just summarize by thanking all of you, one and all actually, to say thank you to this elegant panel. I've got a few things which Karuna referred to, so just to make everyone aware. I mean, we did discuss lots of things, but the key thing perhaps remains overcoming barriers, economic barriers, barriers to access to healthcare, enhancing vaccine awareness, making vaccines cheaper, overcoming cultural beliefs, logistical challenges, asking people to get to the nearest doctor rather than, putting in a car and going to a big city, not necessarily helps. So, it's just trying to make small changes and having such meetings which have practical implications and applying them in some way or the other, besides winter preparedness, which we've all talked about in different ways, about lifestyle, diet, exercise, medications, etc., and certain specific aspects which Dr. Sinha and others relief to. Now, Bihar government has some interesting winter relief initiatives for people, which Karuna was referring to as to what government's doing actually. So Bihar government has something called Mukhyamantri Vriddhajan. Vriddhajan means those who are older. Pension Yojana. So is everyone who's less than 80 but is elderly gets paid 400 rupees, Indian rupees per month, which is approximately, I don't know, might be in GBP, it might be about 3 to 4 pounds roughly. And if you're 80 plus, then you get 500 rupees, which is almost a pound more. That's per month. For permanent residents of Bihar who are age 60 and plus with no other government old age pension. It also has a program called Sustainable Livelihood Scheme, which is to support them in winter. So far, about 100,000 people have been supported. Then there's a Food and Consumer Protection Department, which kicks in around the winter time to try and supply food grains mainly to people who are poor, and also provide subsidized cooking oil, LPG, and ensuring minimum support prices. I'm not sure how much of work's been done and statistics, etc. And the last one is the Rural Development Department, which kicks in its own support mechanisms around winter times, mainly aimed at poverty and poor people. And there are individual websites for all these 4 departments and divisions and streams of work. Now, what is the government of India doing for winter relief program? That's interesting. So there is something called Antodaya Anna Yojana, or AAY, which provides highly subsidized food to the poorest families. Up to people who are eligible can buy up to 35 kilograms of rice and wheat at subsidized rates, aimed in winter, basically to try and get up their stocks. Then there's a public distribution system, which most of you would be aware of. Again, it's food grains at subsidized prices, and it operates through different government authorized shops in the country. And there is a bit of a corruption involved, as you can imagine. And then there are shelter homes and bonfires, which is sometimes arranged through the government schemes. And there's a lot of non-governmental organizations which kick in, or NGOs or charities who are specifically doing their bits to support the winter. And especially in Bihar, we have Action Aid India, Narayan Seva Sansthan, Saviour's Foundation, and of course you have Hridayam Foundation as well. So these are just a few examples that, you know, the world's around you, and besides Rotary Club, Lions Club, it's hard to say who's doing how much and what, but there are a lot of other non-governmental organizations which wintry weather and people who are suffering or are in difficulty depend on and get supported through, besides all the things which we've just covered. So literally, that's it for now. I'm going to share a feedback link. Please take about 30 seconds of your time to provide some feedback. Let me just quickly see the chat box, and just allow me a second, please. So in your Zoom chat boxes, if you look for a link coming through, please. Because we can only get better once we have received some feedback from you about how did you like it, can we make it any better next time, because we're going to have a follow-up meeting as to how we can implement things what we've discussed today. So the next one is about what's happening, who's doing what, rather than talking about the problems and specifics and the barriers, etc. So that's a completely different meeting, more mainly implementation and action based. So you have the link, which is based on what we've covered so far. And then I'm going to also share some resources for people who may want to read and have interest in supporting people or reading some statistics and data. So just and there's a transitioning to the trivalent vaccine, which of course is what is the latest recommendation from WHO, which will perhaps make the vaccines cheaper and more affordable, and more people will have access to it. So that's a very welcome move. And from November, we expect that version of vaccine to be easily available. There's currently just one available in Bihar. Next month onwards, we should have much more availability of cheaper vaccines, at least £1,000 or what, so 1,000 rupees or 10 pounds cheaper than what they are right now. And so these files are just coming whilst you are giving your feedback. So just have them with you. They're interesting. They make interesting read. And There's a poster which might be of help. You can customize it to your needs. They should be appearing in your chat box to download and keep it with you. So with that, I would say thank you from Rhythm Foundation, and on behalf of our kind and senior partners, API, ICP Bihar chapter, API National, and thank you to this panel. Happy Diwali to everyone. Happy Chhath, happy Dhanteras, and a happy festive period. Thank you, Liam. Thank you, Karuna. Thank you, Ajit. And I did see Bula joined from USA. She's been a member of our Bihar cardiology group for a long time. So we had attendance from you as far as the United States. And thanks, NK Singh, for chipping in last minute. And have a very good evening, everyone. If anyone wants to make a quick comment, then we can do that. If not, then good night.
It has been a wonderful day. And I thank and congratulate all the speakers who have done so fantastically well. And the knowledge that we have gained will go now in the elderly people.
Thank you, sir. Have a good evening, everyone. And we'll meet again in the next meeting, as we've just said. Thank you.
Papa Pranam.
God bless you.
कैसे?
बहुत बढ़िया कवर की हो.
Thank you. बहुत अच्छा था ये, बिल्कुल to time. 11 पार्टिसिपेंट अभी हैं ऑनलाइन.
टीपी सिंह अभी आ गए. इतना सारा रखे हुए हैं अपना मेडल्स.
सर आज वो मेरे सॉरी क्लोज हो गया है ना इसमें.
क्लोज हो गया.
क्लोज हो गया है, लेकिन आप चले गए थे. आपको मैं ढूंढ रहा था एक कमेंट के लिए भी. आप लगता है कि आप बाजार चले गए थे कुछ खरीदने के लिए.
नहीं आज सर वो
few participants still logged on.
Yeah. I think
हमारे इसका सन इन लॉ का नॉमिनेशन था.
राइट.
हाँ उसमें उसी से लौटे थे, लेट हो गई थी.
बीजेपी.
हाँ जी सर.
बीजेपी का कि कोई चेंज करना पड़ा.
सर
बीजेपी से कि कोई चेंज करना पड़ा.
हाँ बीजेपी वाला सीट ही दिया गया. बीजेपी का ही.
Move the people who are still logged on. There's
right. It's okay. It's being done. It's being dealt with.
Yeah.
चलिए
ये बहुत ही very nice seminar, and the message was clear cut. So don't treat if you are not vaccinated. That is one message that would I like to hear. Doctors should not treat the patients unless they are vaccinated, especially the elderly or adult physicians and doctors now.
The patient should ask the doctor, are you vaccinated?
ये होगा नहीं sir, because that awareness or level of awareness is not there. But
awareness
message from Dr. Baby Thakur that you doctors don't treat unless you are vaccinated from Hridayam Foundation. That message should be strong, and that should go down. That was the purpose of doing this, and plus arranging that vaccination for patients in the subsidized cost or something like that by the Hridayam Foundation. And so when we talked to Dr. Ashish, said, okay, that's a very nice, we shall go ahead with that. Yeah. So still.
Most of the patients got it free because they are poor.
Sure.
Majority got free.
Yes, sir.
People like us had to pay.
नहीं वो तो सर ये करना पड़ता है, एजुकेट करना पड़ता है सर, और लेते हैं सर. once you educate कि हाँ your flow will be less and you will be better,
चलना होगा.
then the patients will agree with that and they get vaccinated. Yes.
The people will be closed now.
Right, sir.
Yes,
So
sir.
have
Yeah.
a good
night, sir.
have a good
Good night,
festive
sir.
period
Happy-
and good night.
Happy Diwali, sir.
Thank you.
Happy Diwali.
Thank you, Manish. Thank you. Thanks
Madam,
for
प्रणाम
joining.
सर, उस पास पीछे से बैठ करके थ्रू आउट सेमिनार आप बैठी रही वहाँ.
ये हमारा सेमिनार है, हम कैसे नहीं बैठते.
नहीं, आपको नहीं कर रहे, मैडम को प्रणाम बोल रहे हैं.
मनीष, आर यू देयर?
जी सर.
नहीं, मनीष का तो ये सोने का टाइम हो गया.
Right. Good night. I will close the
sir. Good
meeting and I'm a bit hungry now. So thank you so much.
Thank you.
Bye-bye.
Bye.
ठीक है निकी,
जी पापा ठीक है.
बहुत अच्छा लगा, तुमसे मुलाकात भी हो गई.
जी
चलो.
जी पापा ठीक है माँ. गुड नाइट पापा. गुड नाइट. जी जी
Convey our respect to your mother.
जी.
Okay.